So, Carolyn, you're the General Manager responsible for funding and planning at Canterbury District Health Board. Can you tell me a little bit about your role?
So District Health Boards are responsible for planning, funding and delivery of health services for their population. We're population-based funded. So my role is to organise with my team across the whole system, and that includes both the public sector, the private sector and the NGO sector, health and social care services for our population.
So tell us a little bit about the Health Board's broad approach to paying for health services. What sort of payment mechanisms do you use?
Wherever possible, we keep our payment mechanisms as simple as we can. So we unpacked all of the old-fashioned fee-for-service, pay-for-performance type models and went back to a really simple resource allocation model. What that enables us to do is set the expectations of what we want, the outcomes we want the providers to deliver, and then work alongside the providers to make sure they deliver to the population without letting the financial incentives get in the way of the right conversation.
So you made a conscious decision to move away from pay for performance towards block grants or global budgets. So what scope do providers have to make a profit in your system?
Depends on the provider. So in terms of not-for-profits, obviously that's an open book process. We know, they know. And if there are any resources available at the end, then we jointly agree where we're going to spend them. So it's a partnership type model. The for-profit providers, we've agreed a minimum and maximum level of profit. So they're allowed a particular percentage of return on investment. When they go over that, then they have to put those resources back in the system.
So how do you know if a provider has made more profit than you've agreed?
Because it's an open book process. So getting there in the first place, we worked through it with them, we understand their resources, we understand their allocation, and we understand their cost structures.
How do you go about moving money from one provider to another?
So the way it is that we forecast the whole system. So a lot of this is data driven. We forecast the system, we understand what we need to deliver. We also forecast the capacity of the system. There's usually a gap. So in an alliance type framework with our partners in the system, we get in the room, we look at the gap and we figure out how we're going to strategise that gap. What are we going to do differently? Can we reduce demand? Can we increase capacity? What do we need to change in the system? And how do we need to move resources to make that happen?
How are these decisions made? Do providers have an equal voice with the Health Board on resource allocation decisions?
Absolutely. Because we're running an alliance type contract, it's clinically led. So the clinicians in the room make the recommendations about how best to manage the resources across the system. And then it's up to the planning and funding function of the District Health Board to make that happen.
So if a provider does really well, it can make a profit within certain restrictions. What happens if a provider performs really poorly? What do you do then?
So we've had that happen quite a few times in the last few years because we've been running this process since 2010. What happens then is we all get in the room again and we start looking at what is happening to drive that extra expenditure. If it's an alliance with multiple providers in it, then all of the providers get in the room and we share amongst ourselves what it is that's costing more for one provider than another. We've put our finance people in to walk alongside their finance people to understand their cost structures, figure out where their efficiencies could be. So there's a whole range of strategies we put in place to manage that growth. And then we agree a pathway out. So sometimes we've had to put more money in to enable them to get back to stable, but with a trajectory to get them back into a stable position.
Would you allow a poorly performing provider to run up a large deficit or go bust?
No, we'd intervene far before that. So, and also it's about how we define poorly performing. So we're very focused on what is the outcomes that they're delivering. So if they're delivering the right outcomes to the system and they're delivering the right outcomes for our patients, then it's about helping them understand how to manage their business better or understand what we might be doing that's adding more cost to them. Because quite often what we find is there's a huge amount of waste in the system. So to give you an example, our community services providers, which the total pool of their funding is about $37 million, we've been able to leave it at $37 million now for nearly 4 years. But that's because we've all worked together to figure out what we can take out of the system that's waste.
So Carolyn, you're taking a very different approach to what we're seeing in some other health systems. In the US, for example, there's a much greater focus on the use of financial incentives and a move to transferring much greater risk and reward to providers within accountable care system models. Why are you taking such a different approach?
So one of the interesting things about transferring risk in these kind of models is in fact you don't. Ultimately the risk comes back to the District Health Board. Because if that provider fails, as you pointed out, who's going to pick it up? We're not going to suddenly leave the patients without care. So if you step back and realise this is about making sure you've got care for the patients, then you move away from those kind of models and you move more into a partnership collaborative model. What we know is as soon as you start talking about money and contracts, collaboration goes out the window. So we have simplified the system, made it open and transparent, and made it about all of us working together for the best outcome for the patient. Over the years, we have put in a whole range of complex financial incentives. They never work. In a complex adaptive system, financial incentives inevitably become perverse.
Carolyn, thank you very much.